Good afternoon, respected chairperson, my seniors, and honored to be here in this beautiful conference. And after the monumental work presented by Ketan Bhartak sir on ULEP and Dr. Gopal on HOLEP, again Bharshan sir on HOLEP, I'm going to present thulium fiber laser enucleation, that will be en bloc enucleation. And my job has been made easier because I will not go into details of the anatomy, physiology, the instruments, the position and all that. Everything has been so well described. And because I think this is the last session before lunch, as you all know, hungry man is an angry man. So I do not want to be on the receiving side, so I will be trying to as precise and short as possible. Again, my request is not to judge this youngest member of the family that is only 5 years old, fiber laser. Do not judge or compare with the big brother like holmium laser. So let it grow, let it blossom. It has proved its worth. It is very multi-talented, proved its worth on stone, and gradually I think it will prove its worth on laser enucleation too. From BioRes, we have just installed a few weeks back. Earlier also I was using the same modulator, and I will straightforward will come to the en bloc enucleation. As Sir has already said, and it was published in the year 2016 in World Journal of Embryology by Herman et al. That enucleation is an enucleation, is an enucleation, is an enucleation. So the technique matters and the surgeon's experience matters rather than the energy source we use. And this movement of the enucleation assembly to do the procedure, and as you can see, I'm putting the continuous irrigating sheet. I am not using here a visual obturator. With experience, you can do that. And I'll be showing here en bloc enucleation. To start with a 3-lobe technique, as Sir has already demonstrated another 2-lobe technique. It helps. And once you gain in confidence and once you develop the 3-dimensional view of the prostate anatomy, you can shift to en bloc enucleation. Here, a 70-year-old male with 68-gram prostate with failure of medical treatment, and we have taken for thulium fiber laser enucleation en bloc. As you can see, I first put the incision at the floor, and gradually I will try to develop the plan and identify the capsule at peri-varu area, as it has been already shown. And at the peri-varu area, the capsule is thicker and it is very superficial, and you can very easily can reach the exact plan there. And here you will see that the apex is not protruding too much beyond varu, and the apical lobe projects too far beyond the verumontanum. You can cut here, and you cut it deeper till you find the capsule posteriorly, then you can proceed. That prevents the initial stress urinary. So gradually we are nearly reaching 6 o'clock, or you can say we are going little more from the midline towards the right side of the patient. Here you can see that there is a bleeding point which has emerged, and as I have said, that you imagine the course of the vessel and activate the laser with the coagulation setting on above the tissue, not directly on the bleeding point. Here you can see, as I have said, that here intentionally I have gone on a wrong plane. So that I wanted to show you that with thulium fiber laser, or for that matter thulium yak laser, which is a very good cutting tool, you can go easily on a wrong plane also. So here I am going through the adenoma, which is otherwise would not have been possible with holmium laser. So you can say that this is the disadvantage of this laser, but for a beginner it will be easier that even if you are not in the correct plane, still you can complete the procedure, you can make the patient void, because once you completely enucleate the gland, you can come and reassess the tissue, and you can see that there are some adenomatous tissue left, and that tissue you can vaporize with this laser. Though it is a very like in comparison to yak laser, which is approximately 150 watt or sometimes 200 watt, is very strong laser. It vaporizes very well, but with thulium fiber laser also you can vaporize any residual tissue if it is left. So this thing is not possible to go on a wrong plane, leaving behind some part of the adenoma in case of holmium laser enucleation. So we can say that this is again advantage of holmium laser, or at the same time disadvantages also. So if you are not in the correct plane in case of holmium laser, then it will be, you cannot proceed. You have to stop there, or you either go to the injured capsule, and as sir has said, that anesthetist will ask you to stop then and there, or you stop the procedure to complete it with some other energy technique. Here you can see that we have now coming to the, by completely removing the apex, at least for 1 or 2 weeks, you get transient stress urinary incontinence, at least in 15 to 20% of cases. But if you keep some part of the apical lobe, if it projects too much, mind you, if it projects too much beyond verumontanum, then you can just keep it and cut it there. Here, as sir also advocated, that we go for marking the incision for early mucosal release and at 12 o'clock position, but Dr. Gopal showed that he cut it at the last part of the enucleation. But here I too prefer to mark the point at 12 o'clock, because that is the area where you think, or you are afraid of that the sphincter may get damaged, because the sphincter is more proximal at 12 o'clock. So first you mark it, then be sure and get relaxed, and then you start the enucleation. As you can see that here I'm not keeping myself there just at the mucosal level, and I'm developing the plan and taking it forward to enucleate it up to 3 o'clock position on the left side. And being a right-handed surgeon, always we prefer to first enucleate on the left side. Here you can see that this is the difference with holmium laser, where because of the enormous the breaking of the vapor bubble, it will create the plan for you. But here in thulium fiber laser or the other cutting laser, you have to put the TUR assembly to stress out the tissue, the fine attachment between the adenoma and the capsule, and the laser energy is used to divide that attachments. Here in holmium laser you cannot go on a wrong plane, but in fiber laser, because it is a very good cutting tool, you can go on a wrong plane also. So to remain in the plane, you have to properly use the enucleation assembly to remain in the correct plane and to stress out the tissue as gentle as possible. And it is now proved that the marked difference between a novice who takes up laser enucleation and an expert is proper and effective utilization of the enucleation assembly to stress out the fine attachment. Here you can see, and here I am using high energy, 3 joule energy and 18.3 hertz frequency. And here you can see the very fine kind of charring is not there. You can see little carbonization. So you use more energy in thulium fiber laser. Even I have demonstrated in a live operative workshop using 4 joule energy also. Here you feel it that you are almost doing it with Holmium laser, the pulse wave Holmium laser. Here in thulium fiber laser, you have both the properties. You can use it as a continuous mode or in pulse mode also. Now you can see that I am not going to the other lobe, but I am enucleating at the roof also. Here, because I am doing an en bloc enucleation, I will prefer to enter into the bladder at 12 o'clock position, because the gland will be straighter at 12 o'clock position. Otherwise, the prostate is not like cylinder; it is like an apple, and you go more towards the floor, it becomes more concave. So while if you do an en bloc enucleation and try to enter into the bladder at the floor, there is always a possibility that you go subtrigonal. And if you enter at 12 o'clock position or up to 2 or 1 o'clock position, you get a straighter plan. So take down first at the apex at 12 o'clock, the most dangerous part. Then you enter into the bladder at 12 o'clock, and then gradually you come down on the bladder neck part. And as you have already developed the plan on the left side up to 3 o'clock and on the right side up to 9 o'clock, then you can come again the enucleation from the roof. As you can see now, I have completed enucleating on the left side up to 3 o'clock, and to some extent I have dissected and enucleated at 12 o'clock position also. Now I am coming to the other side. Here, while enucleating at the periveru area or at the bladder neck, you get some mucosal bleeding, and you can do pinpoint coagulation by the coagulation setting of this laser, which is again very effective, and then you can proceed. Or even if you do not do or unable to stop that bleeding, still you can proceed, and when you come back to that area and you find that it has already stopped, and the irrigation is kept to very minimum, and you do not have any bleeding there. So that completes the procedure. So my